All right, Crafton students, welcome to another day. Thank you for putting your attendance in the chat. It's great to see you guys. So as we look here, I just am pulling up your schedule. We're back on track with anything if any of you are following the schedule and the syllabus. So today we kind of have another day to get through the heart chapter. And then in lab this week, you guys will have two lab activities to do as we go over blood. And we have a blood typing lab. It says a home lab kit. You guys were not, in previous semesters, we had you guys go to Crafton and pick up a home lab kit. But this semester, we're not doing that because I think the first 6 weeks we were closed down because of COVID. And then our lab tech was kind of out of commission. So just in lab this week, we'll be going, we might just have one activity now that I think about that, because you don't have a home lab kit. But what I wanted to point out, we're caught up back with lecture, and we have just half a PowerPoint of chapter 12 to get through on the heart today. And I won't start chapter 13. So today's lecture might be a little shorter, but please, even if we end short, don't forget to come back to lab if you're in Monday's section. So that's kind of what's coming up. And then we'll spend 2 days going over blood vessels from chapter 13. So your next lecture exam is looking to be next Wednesday. So that would be April 13th. So just keep that in mind. But I'm going to pull up our PowerPoint and we'll kind of start here. I'm going to review a little bit of the conduction system of the heart before we get into the cardiac cycle. And again, this is our second half of our chapter 12 discussion on the heart. And remember, we're talking about kind of the introductory to your cardiovascular system. So we talked about blood, we're going through heart, and then on Wednesday, we'll be going over all of your arteries and veins. But the conduction system of the heart refers to how electrical activity spreads through the heart. And this is very important because your heart establishes its own heartbeat. And if there's any sort of damage to this conduction system, parts of the heart will not beat in sync how they're supposed to. And the electrical activity, passes through a heart or a portion of the heart before that part of the heart contracts. So again, if we don't have electrical activity passing through the heart, then we don't have contraction of that part of the heart, and that could lead to problems. So the part of the heart that kind of starts the electrical activity is the sinoatrial node shown at the top of the right atrium. That electrical activity passes through the AV node, down through the AV bundle, and then into the right and left bundle branches, and then up through the Purkinje fibers that bring electrical activity to all of the heart muscle cells, especially in your ventricles, which are doing kind of the majority of the contracting and the ejection of blood. If you know of anyone who has a pacemaker, what a pacemaker does is a little metal device that is usually kind of rectangular in shape that's inserted kind of where your clavicle is. So that's the pacemaker is the device, and then it has a metal lead that goes through, and the metal wire or lead will bypass any sort of problem throughout this conduction system. So let's say you have a problem with your AV node, it just doesn't work anymore. The pacemaker wire would come in and connect and go through your SA node, and it would bypass your AV node to try to reconnect up with the AV bundle. So that wire would just bypass the damage done to the AV node so that your heart can continue working the way it should. So that's what a pacemaker does. We talked about electrocardiograms, which give us a visual representation of the electrical events of the heart. And they are really helpful for diagnosing any cardiac abnormality, because again, if anything is wrong with the electrical signaling of the heart, is shown here in yellow, the ECG would show a disorder, and that could be helpful for showing where that part of the heart might not be able to function as well. It uses electrodes placed on the body, and it contains a P wave, a QRS complex, and a T wave. The P wave stands for when your atria depolarize. So when you see this little kind of green hump in the graph, that's your P wave. So right after you see your P wave, your atria will depolarize, and then your atria contract. And then the QRS complex stand for when your ventricles depolarize or the electrical signal passes through your ventricles and your ventricles contract. And then the T wave stands for when your ventricles relax again. So this ECG showing the P wave, the QRS complex, and the T wave, this is like one heartbeat where your atria contract, your ventricles contract. And they're all measured based on these little gray boxes, and each gray box is about 0.4 milliseconds. So, medical professionals, people who read ECGs for a living, monitor these intervals between the P and the R complex. We call that the PQ interval. And if that interval is longer or shorter than it should, it would indicate that there's some sort of problem in the heart's electrical activity. So that's the electrocardiogram, and we kind of got through that at the end of last time. I just wanted to review that briefly before we get into the cardiac cycle now. The cardiac cycle is a summative description of all of the events that occur during one single heartbeat. So your cardiac cycle includes all the mechanical events of the heart, so like the contracting and the ejection of blood. It includes all the electrical activities of the heart. So your cardiac describes all of these electrical, mechanical, pressure, volume changes of the chambers, how everything kind of comes together in a really kind of beautiful orchestrated event in order for your heart to pump out blood how it should. Remember that the heart is a two-sided pump with your atria being primers or filling up the pumps of the ventricles. So your ventricles are the actual pumps of the heart. The atria just fill up those ventricles, and then your ventricles will contract and eject the blood to the appropriate spot. Your heart chamber contractions, so your cardiac muscle contractions, will produce pressure changes within the heart chambers. And these pressure changes within those chambers are responsible for blood movement. Blood will always flow from an area of high pressure to low pressure. And that makes sense. Your blood will be really kind of building up pressure in the ventricles. And when the valves open and your ventricles contract, that blood will flow to an area where there's less blood pressure. So that is important with heart chamber contractions. We have words that we call systole and diastole, and they all refer to the atria and ventricle chambers. If you hear the word systole, systole always refers to contraction. So if we have an atrial systole, that's contraction of the atria. And ventricular systole, this refers to ventricles contracting. And then we have kind of phases of the cardiac cycle called diastole. And diastole means relaxation of those chambers. So atrial diastole is relaxation of your atria, and ventricular diastole is relaxation of the ventricles. And here are the different phases of the cardiac cycle. And I think I wish I could zoom in even more, but if we start here with number 1, if you zoom in on the PowerPoint, you can see how the atria and ventricles are all relaxed in this first phase of the cardiac cycle. What's occurring during this is you see the white arrows refers to the direction of blood. So during your first kind of phase of the cardiac cycle, and remember that the cardiac cycle is one heartbeat. The cardiac cycle is everything that happens within one heartbeat. You see the white arrows refer to blood flow as your ventricles are filling with blood from the atria. So you see blood flow with the white arrows going from your atria on both sides of the heart to fill up your ventricles with blood. Phase 2 of the cardiac cycle, the atria kind of contract, so they kind of squeeze a little more to finish filling up all the ventricles that are below them with blood. And then phase 3 refers to the contraction of the ventricles, which causes pressure in your ventricles to increase. So during this phase 3, it says here that all 4 of your valves are closed. And remember, your valves open to allow blood to be ejected. And during phase 3, the ventricles begin to contract. And when the valves are closed and the ventricles begin to contract, that helps to build up pressure, to get ready for kind of this really strong ejection of blood that will occur during phase 4. So finally, during phase 4 of the cardiac cycle, the continued contraction from the ventricles causes the pressures in the ventricles to exceed or supersede the pressure in the pulmonary trunk and aorta. And that causes the semilunar valves to open. So you start to see these white arrows now showing direction of blood flow from the ventricles through the aorta, which is in red, and the pulmonary trunk, which is in purplish blue. So this is kind of a final forced contraction of your ventricles, which is now forcing ejection of blood out of the heart. Remember that blood flow through the pulmonary trunk goes to your lungs to pick up oxygen from the right ventricle, and blood flow from the left ventricle through the aorta is taking that oxygenated blood to all parts of the body. And then at the beginning of ventricular diastole, so when your ventricles relax again, the ventricles relax, the semilunar valves close, and that's our second heart sounds. And we're going to go through what heart sounds are, the lub-dub, 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 that your doctor listens for in the stethoscope. What he's actually listening for are the closure of the valves, and we'll go over what that is. All right, so here we have the events of the cardiac cycle. And again, this event is showing all the events of the cardiac cycle. So everything that's involved within a single heartbeat. We have electrical events showing the PQRST complex. And this kind of graph, there's a lot going on in this graph, but it's showing how everything kind of lines up together. So you'll see between the P and the R complex, how the semilunar valves will open, AV valves close, and you'll also see ventricular, left ventricular volume and pressure changes. Way at the bottom, I'm going to kind of point your attention to these heart sounds at the bottom. This is the first heart sound. And this refers to when your atrioventricular valves close. So you'll notice that right after, the ventricles become depolarized, the AV valves close so that blood flow will not go back into the atria. And the second heart sound refers to when the semilunar valves close. And this occurs after blood has been injected. Remember, your semilunar valves open into your aorta and your pulmonary trunk. So right after blood is ejected into those two main arteries, those semilunar valves close. And these heart sounds, make up the lub-dub, lub-dub, lub-dub. When your doctor's listening in the stethoscope or nurse, they're making sure that these valves are closing all the way. If these valves aren't closing all the way, your ventricles can't build up the pressure they need to fully eject the blood that's in them. So we call that a heart murmur or a valve prolapse if they're not closing all the way. And that could just lead to some real problems because it means your heart isn't functioning at maximum capacity, which means your body's tissues aren't getting the oxygen they need. So that's why a simple diagnostic tool is the stethoscope. What the doctor could listen for is instead of hearing the lub-dub, lub-dub, lub-dub sound, you might hear like a whooshing noise in between them. And he's hearing actually blood flow back into a chamber it shouldn't be going. So these heart sounds, again, are produced due to the closure of your heart valves. The stethoscope is the medical device used to hear them. The first heart sound is due to the closure of your atrioventricular valves, the tricuspid and the bicuspid valve between the left and right atrial ventricle. And the second heart sound is due to the closure of your semilunar valves. And your semilunar valves will open and close to the aorta and pulmonary trunk. So those are your heart sounds. Here are heart valves locations. So in blue, it actually shows you the actual location of the heart. And then in pink, this is where kind of the sounds are projected onto the surface of the skin. So your doctor or nurse should be listening to your heart in these 4 different locations on your skin, because in these spots, he can best or she hear for those closure of those heart valves. So, the next time you go to the doctor's office and you get a checkup, see if he or she listens to your heart in these 4 different spots that I've outlined in pink, because this is where they're listening for these 4 valves to close all the way. Regulation of heart function. We can kind of measure how well your heart is functioning. And this is really important to just measure if your heart is doing what it should be and getting blood supply to all the tissues that need it. Stroke volume is the volume of blood pumped per ventricle per contraction. And it's about 70 milliliters per beat. And stroke volume is really important, and it's able to be measured mainly through diagnostic imaging. So they can get an image of your heart and measure the volume of the ventricle to try to see how much blood that ventricle could contract. The heart rate is the number of heartbeats in 1 minute. An average heart rate is about 70 beats per minute. Some people have lower heart rate, especially athletes. Their heart is like a muscle that they've been working out a lot. So some athletes have very low heart rate, but their heart is still functioning normally. Some people can have faster heart rate. Your heart rate usually increases if you're exercising or you're stressed out or kind of nervous. So that's kind of 2 ways we can measure heart function. Cardiac output then describes the volume of blood pumped by the ventricle in 1 minute. So again, medical professionals, cardiologists will measure cardiac output of a patient that might have a problem with their heart, just to see how much blood their blood is actually pumping. So cardiac output describes the volume of blood pumped by a ventricle in 1 minute. An average is about 5 liters per minute. When you think about that, 5 liters per minute is a lot of blood that your heart is pumping out. For an organ the size of your fist is pumping blood out at about 5 liters a minute. That's like, again, a size of a liter of soda pop, and 5 of those in 1 minute. That's a lot of blood that an organ the size of your fist is pumping out. That cardiac output number, 5 liters per minute, is equal to the stroke volume times the heart rate. So, different things can affect the cardiac output, the heart rate, the stroke volume, and different things then in turn will affect your heart rate and stroke volume, which will affect your cardiac output. So cardiac output, again, is an important number to measure, especially when we're talking about someone with maybe a heart problem. The intrinsic regulation of the heart just refers to mechanisms contained within the heart itself. That means intrinsic. So these are within the heart itself that are controlling its cardiac output. Venous return is an intrinsic regulation of the heart. So venous return refers to the amount of blood returning to the heart each minute. Preload refers to the degree that the ventricular walls are stretched at the end of their relaxation. And venous return, preload, and stroke volume are all related to each other. This intrinsic regulation, we formed what we call a Starling's law of the heart. Again, this law was created by someone named Starling, and it just describes the relationship between preload and stroke volume. So it's just pretty much describing what influences your cardiac output. For example, exercise increases venous return. So that's one reason why exercise is so good for you, because it increases the rate at which your veins return blood to your heart. Preload, stroke, so exercise not only increases venous return, exercise increases preload, how your ventricles, how they can stretch, the stroke volume, and the cardiac output. So exercise is really good for your heart because it gets your heart working, functioning, and kind of practicing being able to output the blood that it needs to. And the afterload refers to the pressure against which the ventricles must pump the blood. So afterload is the pressure at which your heart needs to pump out the blood. And then the extrinsic regulation of the heart, this refers to any mechanisms external to the heart that help to regulate its function. So such as nervous control, control from the brain, for example, or chemical regulation of the heart. Nervous system control of the heart occurs through sympathetic and parasympathetic divisions of your nervous system, and these will help to influence heart activity, all carried through the autonomic nervous system. So remember, when we talked about nervous system, your autonomic nervous system, we divide it into a sympathetic and a parasympathetic division. The sympathetic division will increase heart rate, and the parasympathetic decreases heart rate. And both sympathetic and parasympathetic nerve fibers will innervate the SA node, because remember, the SA node controls the rate of kind of the electrical signal that passes through your heart. So sympathetic fibers will increase SA node to try to increase heart rate, and parasympathetic nerve fibers will slow down your SA node. And then the baroreceptor reflex is another extrinsic control. It's a mechanism that your nervous system uses to help regulate heart function, and it uses what we call baroreceptors, which help to monitor blood pressure in your aorta and the carotid arteries. So your aorta is the big artery that comes out of the heart. Carotid arteries are actually arteries that go up to the brain. And these baroreceptors monitor changes in blood pressure. These baroreceptors take in changes of blood pressure that are changed into action potentials that then go up into the brain, the medulla oblongata. So this baroreceptor reflex, it's monitoring these blood pressure changes in the aorta, your carotid arteries. If blood pressure is too high, the baroreceptors will pick up on that. And then your cardioregulatory center in the medulla oblongata picks that up to try to send out a response to slow heart rate down. So stroke volume decreases and blood pressure decreases back into normal range. If another homeostasis is disturbed, if blood pressure decreases too low, that also is picked up by baroreceptors, and it sends out an effector to try to increase heart rate to your SA node, to try to increase blood pressure back into normal range. So those are how your baroreceptors, part of the nervous system, try to keep your heart rate into, or heart or blood pressure volume into a normal range. The chemoreceptor reflex involves chemical regulation of the heart, chemo for chemicals, and different chemicals can affect your heart rate and your stroke volume, and the chemoreceptor reflex kind of keeps track of those chemicals. For example, what are different chemicals that can affect your heart rate? Epinephrine and norepinephrine from the adrenal medulla on your adrenal glands that sit on top of your kidneys can increase heart rate, can increase stroke volume. Excitement, anxiety, we all know anger can increase your heart rate, but when we say heart rate, we're meaning also cardiac output. Depression can actually slow down your cardiac output. And the medulla oblongata, which is that portion of the brainstem connected to your brain, it has different chemoreceptors to help keep in changes of blood pH levels. It's really important for your pH levels to be always in normal homeostatic range, as well as carbon dioxide levels. Other ions that can affect cardiac function are potassium ions, calcium ions, and sodium ions. So again, the chemoreceptor reflex kind of keeps track of all these chemicals, whether it's a hormone, epinephrine, norepinephrine, pH levels, cardiac output, or potassium, calcium, and sodium. And this is just a look at how the chemoreceptor reflex controls pH. So for example, if blood pH levels get too high, that kind of disturbance is picked up by the chemoreceptors, again in the medulla oblongata, which help to decrease activity of the heart, decrease stroke volume, to try to decrease blood pH levels back to normal range. And the opposite occurs if blood pH gets too low. So this is just a general summary of everything extrinsically that's controlling cardiac output and your heart rate. So again, extrinsic regulation, these are regulatory kind of mechanisms outside of the heart, extrinsic, that are controlling function of the heart. And again, most of them are controlled in the cardioregulatory center, which is in the medulla oblongata. So we'll see sensory nerve fibers that bring information from the heart, whether it's a carotid, chemoreceptor, a baroreceptor. It's kind of processed in the medulla oblongata and then sends out some sort of response, whether it's a parasympathetic fiber that slows down heart rate, a sympathetic fiber that increases heart rate, sympathetic fiber that could cause epinephrine and norepinephrine to send to circulation. Those are again, our adrenaline hormones to also increase heart rate. So I don't think you need to know exacts of this, but you should know that you have a lot of extrinsic factors, usually in the nervous system, that are controlling heart rate. At the end of each kind of body system talk, we talk about how your body is slowing down or disease to that particular organ. And unfortunately, heart disease is not fun, because if there's something wrong with your heart, it will affect, it will lead to damaging effects everywhere in the body. Coronary artery disease has to do with a disease within the coronary arteries of the heart, which are the arteries that are supplying blood to the heart muscle itself. And usually it means that these coronary arteries are narrowed for some reason. Plaque can build up in these arteries, so that leads to a decreased blood supply to the heart. If it builds up so much, there might be a blockage within these coronary arteries. And if there is a closure or a blockage of one or more of these coronary arteries, that will cause a myocardial infarction, an MI, a heart attack. And that's because that area of your heart, that muscle, is not receiving the adequate blood supply that it needs. So that area of the heart cannot contract because it's not receiving oxygen it needs to contract. So that part of the heart will die, and it would cause a scarring, which is actually the infarct. And that is what a heart attack is. Some different heart procedures to take care of kind of heart problems, specifically coronary artery disease, might be an angioplasty, which helps to open up blocked blood vessels. A stent might be inserted, which is a little metal mesh. So it's inserted and then it's expanded. And you have this little kind of metal mesh to help expand your coronary artery vessel to keep the blood vessel open. If those don't work and there's an actual kind of blockage or clot, you might need bypass surgery. And this will use kind of a graft from another artery to bypass or reroute the blood away from the blocked artery. And again, if that happens 3 times, that's called a triple bypass surgery, which is not a simple procedure. So that's the end of this chapter, taking us through chapter 12. I told you we might get done with lecture a little early today. I'm not going to go on and start the next chapter because, as you can see in our syllabus, we're right on schedule now. So we'll spend the next 2 class periods going over blood vessels, and then your next lecture exam will be next Wednesday, April 14th. We will have, exercises and activities to complete in lab the next 2 weeks before your next lab practical exam. So please show up for lab. We have about an hour break now before lab, so please come back for that. But otherwise, that's all we'll do in lecture today, as we're kind of caught up in our syllabus, and I don't want to start the next chapter. So thank you for listening, guys. I'll go ahead and stop my recording.